So just a couple of questions and a thought, like, is it possible to use, so you just have to get them colder, right? That's the main, I mean, is it possible to use something like liquid helium instead of nitrogen? Is that just too expensive?
It is possible to use, I mean, CO2 is also, gets very cold, argon gas, but liquid nitrogen we found is minus 196 degrees, and it's relatively inexpensive. So it's readily fluid, it's not, you know, it doesn't have any, it's used in a lot of places. So we opted for liquid nitrogen, basically.
And then my other thought was, when you start doing this, when the chest wall is still connected to the pig and you have blood flow, I wonder about packing the lining of the chest with something like epi-soak sponges or something to decrease blood flow, since you're just trying to go a couple of millimeters. The other thing is, I wonder about pre-treating the chest by trying to decrease the solute at the cell level, you know, the osmolality in the cells, maybe by, you know, dwelling with some distilled water or something like that before you treat. I don't know if that would help. Something that would get into the cells, like I guess DMSO, would actually lower the freezing point and preserve the cells. So, but pre-treating with something, I wonder if that would help the problem.
Yeah, we've thought about that already, and we already have similar. You know, we have the the hypothermic experiments that I showed. We also have experiments using water mixed into that we're, you know, about almost done with. So that's the next step, is to add in water pre-treatment, just to swell the cells and then freeze them, and maybe at a higher temperature they'll burst and rupture, so that they'll become things. You know, the thing about the big unknown is really the chest has lots of blood flow through it. So, you know, freezing the chest other than the surface is not necessarily an easy thing to do. But on the other hand, that may be the beneficial thing about this, because you really only want to freeze the surface. If you start freezing too deep, particularly with any size blood vessel, that blood vessel is going to probably rupture too, and you have lots of bleeding afterwards. So that's the one caveat that we're thinking about. It may be a problem, because if you do cryoablation percutaneously versus radiofrequency ablation or microwave ablation, there's much more temporary bleeding. So that clearly happens to small blood vessels that are in the area. But you know, actually soaking it with epinephrine soaked laps or something actually might be a good idea for all that purpose, just to decrease the blood flow and then decrease the problems with bleeding after doing cryo. But we're looking forward to trying to try this in a live animal model to see what actually happens in the pleural space.
I'd be happy to share with you. I didn't go into it, but the physics core from our pilot project, from our program project grant, actually one of the things we have is optical measurement at the tissue level of capillary blood flow and tissue oxygenation. But the capillary blood flow would probably, you know, at that level is all measured optically, and you know, we could actually collaborate with you if you want to see what's going on at the capillary level as well as something you can measure optically. Although, as I think about it, I guess if you freeze all their stuff, they'd be mad at you. But
my PhD was in optics, actually, for tissue oxygenation, so that's why I'm.
Yeah.
So that probably would be actually, you know, as long as we don't occlude the blood flow basically with the frost for the optics to work, then yeah, that'll be actually good.
It would be interesting, actually, if you did watch the blood flow, and if it started to get to the point where you're occluding the blood flow in an area you didn't want to, that would be an interesting way to monitor it, actually.
And we use what we describe as a cancer registry centric information model based on NACER, the North American Association of Central Cancer Registries, as the core data set. So the standard I talked about, most of the clinical data collection is NACER specific. And what's nice about NACER is approved by the surgeons, the pathologists, the oncologists, and you know, the CDC and most state registries as the verified clinical source for state reporting. Now, it's not all that you need, but it's 60% of everything to start with. So 60% of all the data elements are not our standard, it's the standard of NACER. And each approved cancer center has, through ACOS, has to stand up those elements. And what's nice about it is most clinical systems for cancer registries also use those elements. So 60% of the stuff is very standardized according to NACER. They keep up with TMN staging. We know the mess that's in mesothelioma that we can't entangle from, but any changes we make, we essentially then ascribe to NACER changes. So we update the database about twice a year. So every site uses those 60 elements. In addition, 40% of the elements were agreed upon by the researchers in the community that is us. Those elements are extensions, and that data model, the CDE paper, which was published in 2007, has the entire data model. It not only describes each data element, but how you record the data in that element, and it also then does the important thing for us nerds in informatics, aligns metadata, so describes the data so that it's callable and queryable by the database. So it's a pretty thoughtful information model that we use. That being said, we started off with over 230 elements when we launched it, and then a year into the program, I always go in and say, okay, so what are we able to capture? Turned out that over 100 of the elements that we thought we could capture, we just weren't collecting it. So we've skinnied it down to about 113 elements. And again, we can share that with you. In fact, if you want to know the elements, you can go onto the website and pull down the CD, the common data element description. So it is very standardized to each site. The bigger problem is the ability to collect all that data. So the model standard, the hard part is to get all that data out of your system, meaning your physician offices, referring offices, et cetera. For the prospective patients, we ask the patients for us to be able to directly contact them if we need to. We do that very rarely, but we do get the privilege to go to physicians' offices, go through their charts, et cetera, and we do that pretty often. So it's a pretty thoughtful model of how we do the annotation. To be very straightforward about it, we only get 70% of those 113 elements on cases on average. But if you look at that, that's a pretty good starting point. And again, constantly improving that as we continue to annotate over time. So something that's different about our specimens, again, being a pathologist, I get to be pretty specific. So we don't just count on the pathology report for the histologic typing. For any specimen that goes out the door, each specimen, and this deals with the heterogeneity issue, gives you a sample that's classified according to histologic type for your own research purpose, plus letting you know if the tumor that epithelioid area came from was from a biphasic tumor or a monophasic tumor. The microarrays are even more carefully characterized in that regard for quality control before they go out for final approval. And the feedback for the TMAs in the hands of researchers, they just love it because it's very cheap, it's effective, quick turnaround time, they're already constructed, and they have all of our clinical data. So it's been very effective. And again, this year I think we'll eclipse TMA being the most commonly requested specimen. Because again, you get so many more patients. So each of the sites has done their first generation tissue microarrays. We're now constructing additional tissue microarrays. And by the way, now on that file that goes with them, we've done all of the major markers for mesothelioma immunohistochemically and are going to include those IHC markers along with the data files in a paper we're putting together right now. So the histologic characterization of the TMAs is published along with the actual clinical data. So a pretty unique resource in that regard.
No other questions?
Just out of curiosity, how many people knew about that virtual bank? Raise your hand. So our marketing isn't very good. Okay. Well, we'll have to continue to get better.
To get any mesothelioma-related stuff out there.
For free. Paid for by the Center for Disease Control. 1,200 cases.
By your tax dollar.
Yeah, your tax. Yeah, no, it's not free. Free to you to use.
I have a question, Dr. Kostic. What are you trying to achieve is during surgery using these freezing techniques? And basically, you have a surgeon that has done a near complete resection, right? This is a resectable patient. And then you have what? A few nodules in critical areas that you're trying to spray and basically kill, or what?
I'm not a surgeon, so that's
Yeah. This is Marko just doing the dirty work. The clinical stuff is mine. No, the idea is that Raja Flores and others and Joe have mentioned is that we can remove everything that you can see. Obviously, there's microscopic disease in the vast majority of patients that are still left diffusely. So the question is, how do you extend your surgical margins another millimeter or two to incorporate most of those cells that are still sitting at the edge? So this is an idea where we found out from just doing some studies that we didn't even suspect to begin with that freezing cells was the most effective way to kill these cells. That's a non-targeted thing. It's just very non-targeted therapy. So, but when you go into the chest after you've done surgery, and if you were to freeze the entire surface that you've just opened up, you would extend your surgical margin that much farther. And one of the things about all this tissues inside the chest is that there are lots of blood vessels in there, and it's kind of almost a self-limiting process in that if you try to freeze something that has a lot of blood flow, it won't freeze. We can't do that percutaneously. We can't do it open. So what you want to do is just freeze the really vital tissues on the surface of what you've just taken out to try and extend what you did surgically. And so the idea and the reason we had to develop this sprayer is because there are sprayers available clinically, but they freeze literally a millimeter or two surface area, and we need to freeze the entire inside of the chest. So in order to do that, we're going to need to have something that flows pretty fast, freezes pretty quickly, and it has a pretty wide area to cover. So we have to do it probably 2 or 3 times. So doing that whole process, we're going to have to have something that's pretty efficient.
What's the average time? I mean, you're holding the nozzle and then you're just doing like this, or I mean...
Well, that's what we're trying to work out now, exactly what we're supposed to be doing. Because we don't want to randomly just start freezing things inside the chest, but...
We need to do animal trials. I mean, that's...
Yeah.
I mean, because there is liquid nitrogen bottles you can use.
Right. We want to be a little more scientific than that. So.
No, but I'm trying to get a feeling which area, because, I mean, if
there is potentially an area that you're more concerned about, you can spray it for a longer period of time. The diaphragm, for instance, you could spray with the cells there on the surface and cover the surface. We already have plans of how to do this. We could put a little catheter inside the pericardium and put warm fluid in the pericardium and then freeze the surface of the pericardium so only the surface gets frozen. You can extend your margin to things like the esophagus, where the tumor oftentimes is adherent or growing superficially into the esophagus, and then you can freeze the area that's exposed. And so you can go all those areas. The areas that we're not really necessarily planning on freezing are the big blood vessels like the superior vena cava and things like that, which are very thin-walled, and you wouldn't want to necessarily compromise their integrity. But you can freeze the surface of the aorta. You can freeze a lot of different things. So we're going to plan on freezing everything, but we have to calculate actually what the time interval is that we're going to need to cover each one, and then kind of plan that appropriately.
Is there a time already?
There's no set time right now.
I mean, do you know what amount of time do you need to hold the sprayer on a specific area to kill the surface or to kill the...
from the data in vitro that we have, it's 5 seconds.
5 seconds, but in ex vivo?
Or 5 minutes, sorry, 5 minutes.
For what we did when we spray it, the surface gets cold within just a few seconds. So depending on which nozzle we're using, the flow rate, obviously, and depending how deep, but we saw from our thermal profile, from the thermocouples, that we don't penetrate so deep, which is a good news, actually. But that's ex vivo data, and that, we need a lot more work. We need more research, so it's not going to get used tomorrow or in a month. So we need more data, more experiments, and more realistic.
There are a few hurdles to get over still.
Basically, you're also allowing the normal tissue to recover after that, after the freezing, right?
Well, no, the idea is actually if you cycle it, you actually kill more cells. So if you do it not as long, you do it for 3 minutes and you cycle it 3 times, you'll get a lot more cell kill by allowing them to freeze thaw. And so ultimately, our plan is to do that. Like Dr. Friedberg said, we're planning to use other adjuvant things, which we have a couple of things that we're add in to pre-treat the cells until we do the cryo, and then we're going to plan to add things afterwards. In the whole scheme of things, we're going to add some adjuvants, immune adjuvants, to help stimulate the immune system to focus on the dead tissue once we leave it there. So, because if you thaw a bunch of cells, that's one of the ways to prepare, immune preparation for vaccine. So we're going to plan to use that for that as well. So there's a whole scheme that's
so you're
worked out.
altering the cells and the immune system might take over.
Right.
Is ethyl chloride out?
I think so. I mean, I don't know.
It freezes very well.
Yeah. It's got, it's a physical thing. I'll leave it to Dr. Kostic to do that.
Basically, we determined that basically the liquid nitrogen would be the best solution basically for our system.
You have not tried ethyl chloride?
We have not tried it, no.
I have a question. How do you get the spheroids to start? I mean, what stimulates them balling up and staying in culture and growing beyond the
It's actually quite simple. You just create a non-adherent culture system, and they self-assemble.
They just self-assemble,
Yeah,
so
so
they
it does
grow.
not require any type of synthetic or exogenous matrices.
So to get to 1,000 cells in the spheroid, what's the timeline from initial aggregation to 1,000 cell spheroid?
1,000. We actually start out with between 1,000 to 2,000. They assemble overnight, literally within 12 to 14 hours.
So it's just the agitation culture?
Yeah, we can allow them to self-assemble from a suspension, or usually we just centrifuge them down just to get them together quickly, and within 12 to 14 hours, they're a tightly packed ball of cells.
Yeah. If you use a coated round bottom well plate, it all just kind of settles down there and it sticks together.
It seems magic.
Yeah, it is.
I have a question for Dr. Wong. Can you explain the phenomena that Dr. Hassan described, based on the immunologic mechanism you described?
Yes. Yes,
Too
it
early.
does seem a little bit counterintuitive.
Too early.
I think it's a battle of.
He's a magician, he's not Houdini.
It's a battle of immune depletion versus immune stimulation. So, I think it was already suggested earlier that there, might be some removal of, immunosuppressive cells, or, possibly, creating room within the immune system that allows, anti-tumor T cells to repopulate.
You don't think like it's an exaggeration of response post-chemotherapy? You have cytoxin, pentostatin suppressing the immune system, and then you have a rebound of the immune system after a certain period of time with massive infiltration of tumor cells or so on?
No, I think that's a reasonable hypothesis. I think there's a number of people at the NCI, Stephen Rosenberg's group, who will buy into that idea that if you lymphodeplete and then you reconstitute the immune system, you're probably either removing immunosuppressive cells or just creating room for anti-tumor T cells to expand.
Nobody's actually really figured that out. I mean, the cytoxin's been known for a long time that it does something, whether it's lymphodepletion or depletion of a certain subset of suppressor cells. But one of the interesting things that I did when I was in the lab at the NCI was we tried to look at local effectiveness. So we used radiation, because right now, actually, Steve Rosenberg's lab has used whole body radiation and conditioning to pre-treat people before giving them immunotherapy and cytotoxic T cells, doing the whole body instead of just giving cytoxin as a single agent. So that seems to have raised the response rate dramatically for melanoma and a few other tumors. So what that's doing exactly, nobody really knows. But when I was in the lab, we did actually localized pre-treatment of liver metastases with radiation, and then treated with immunotherapy, and the immunotherapy worked dramatically better after just pre-treatment with radiation. So, theoretically, if you radiated what you were treating, you get rid of any kind of, lymphocytes and all that kind of stuff. So, what that actually was doing, we never really figured out. But somehow, if you eliminate the cells that are there and allow the system to regenerate with a fresh start, you can potentially generate a lot of cytotoxic cells that theoretically will be much more effective because the microenvironment in the tumor has been altered somehow.
It's just that you look at the PET scan immediately after, then there is an exaggeration or worsening of the PET scan. So there must be some tumor infiltrating lymphocytes or whatever that happened then. cause severe inflammation or destroy the tumor, and then that's where you get the results ongoing for a protracted period of time. So.
The good thing about the steroid model is that Raymond was going to get to more is we're going to add components of the immune system back into that model and see what happens within the tumor microenvironment. So we're going to be able to add in specific subsets of T cells and suppressor cells and actually see where in the tumor things are happening and look at with differential gene expression to figure out what it is that's actually suppressing them and what cytoxin and other things are potentially doing to reverse it. Any other questions? Take a break, 15 minutes.